Cancer Institute experience, and guidance on allocation of limited resources in the oncology community. Next slide, please. I need to always read that the presentations and answers to questions about our COVID-19, our presentations and these webinars are provided by the American Society of Clinical Oncology for voluntary informational use by providers. This information is not intended to substitute for independent professional judgment of the treating provider in the context of treating an individual patient or developing practice policies and procedures. Next slide, please. Just as a reminder now, we've been having these webinars since mid-April. At least at that time, there was a peak in the COVID-19 pandemic around the world, and we had weekly webinars. We've now decreased the frequency of webinars to monthly, and they will occur on the last Tuesday of each month at 8 a.m. Eastern Time, and they last 45 to 60 minutes. There usually will be 2 or 3 presentations with a chance for questions and answers. All of these webinars are recorded and are posted on the webinar series page. If you have colleagues that would like to see this, that were not able to do this real time, or if you want to go back and review some of the presentations in the past. Next slide. So it's my pleasure today to be able to introduce, first of all, our collaborator, Doug Pyle, who is our Vice President of ASCO International Affairs, and he will do the wrap-up at the end of the session today. The heavy lifting will be performed by our moderator, Mr. Alvaro Rogado, who is the Executive Director of the ECHO Foundation in Madrid, Spain. So I'll turn this over to our moderator, Alvaro. Alvaro, thank you for helping us do this series.
Thank you very much, Steve, for your kind introduction. And also, I would like to thank you for putting this interesting global waiting and cancer. Through this series, we are able to share very interesting experiences around the world, and I hope it can help all of us in our fight against COVID-19. I also would like to give a special welcome to all the attendees who are following us today. Thank you for being here with us. It's a great honor and privilege for me to participate and moderate this interesting webinar. Today, as Steve said, we have 3 top international speakers who will be sharing with us their knowledge and experience related with cancer and COVID-19. Each of them will have 10 minutes for the presentation, and at the end of the 3 presentations, we will have a 15-minute question and answer session. We encourage all the attendees to send their questions or comments through the WebEx Q&A box that you will find on your screen. If we are not able to address all the questions from the audience due to the limited time, you are very welcome to visit the COVID-19 Resource Centers at the ASCO website page. I will go straight away and present our first speaker, Dr. Andrés Cervantes. He's a medical oncologist, head of the Medical Oncology Department at the University Hospital of Valencia, Spain. He's professor of medicine at the University of Valencia and scientific director of the Institute of Biomedical Health Research in CLIVA. His main areas of interest are research are gastrointestinal and gynecological cancer, phase 1 trials, and development of new drugs. He's also editor-in-chief of the journal Cancer Treatment Reviews and the associate editor of Annals of Oncology and ESMO Open. He's also currently the president-elect of ESMO. Welcome, Dr. Cervantes, to this webinar, and you can now proceed with your presentation.
Us for having me on board and for having this invitation. I feel honored about this. I'm going to tackle on how to keep communication within a team during the COVID-19 outbreak. Can I have the next slide, please? Those are my disclosure. Most of them are related with my role as a PI in many trials. May I have the next slide? So just to start, I would like to make easier to understand the whole issue. I would like to describe our setting, our department. I work in academic medical oncology department. Our hospital is having almost 700 beds. We have a bit less than 2,000 new cancer cases per year. We have a small inpatient unit with 28 beds. We have a large outpatient clinic looking after 200 patients every day. And our infusion center works from 8 o'clock in the morning till 10 o'clock in the evening, and we treat an average of 90 patients per day. We have also a very active clinical trial unit treating in early clinical trials about 200 patients per year. Our team is made up by 16 medical oncology staff members, and we also have 10 medical oncology trainees forming part of our team. Next slide, please. So at the very beginning of the COVID-19 outbreak, we have to deal with a lot of uncertainty. So lockdown was mandatory all over Spain in March 14th, and then the hospital managers established some priorities. All non-urgent consultations and visits from patients were totally cancelled. A very specific COVID-19 circuit was established for any suspected patient. And at the same time, we have to consider that some symptoms like fever or respiratory symptoms are common among cancer patients. And also, no physical meetings of doctors were allowed to facilitate physical distance. So then we had to discuss a series of actions to get implemented and to facilitate interaction among members of our department to keep them not only informed but also engaged in the common aim we have to be close to cancer patients. Next slide, please. So, to keep communication within the team during the outbreak, we decided to establish 2 daily WebEx meetings for all doctors in the department. The first one was done 8 o'clock in the morning before starting the day, and the second at 14:30 before ending the working hours. And those 2 meetings have to be attended by all staff members and trainees in the department. And it was planned that those meetings could take between half an hour and 1 hour each. In the meanwhile, all new rules and protocols provided by the upper management or even by the health authorities were sent by email to all members of the department. Next slide, please. So the critical issue was first the aim of those WebEx meetings. First was to keep all members of the department informed on any new rules or protocols established by the health authorities or by the hospital upper management, to keep them informed on the global COVID-19 situation and related activities as well as relevant scientific information, to share the way of assessing and approaching any potential conflicts or difficult situations, to reinforce a team-building attitude in all actions, particularly in patient care, and facilitating engagement, and also to create a supportive atmosphere, facilitating discussion and sharing experiences. Next slide, please. So about the content, very important. So we structured the two WebEx meetings in the following way. So 8 o'clock in the morning, it was very important to start by a report of the two doctors on duty on the incidents during the on-call period the day before. For example, to be concrete, how many new patients were hospitalized, how many patients did go through the COVID circuit, what was the final outcome on the COVID-19 PCR test for all patients seen, was the protocol and the pathway kept or broken at any moment, just to fix if there were any issues in implementing the protocol, and then assessment of times to take a decision and to complete that particular circuit, and also to update the rest of the team on how patients already hospitalized were doing. Then this was followed by a brief report by the head of the department on the global COVID-19 related activity in the hospital. How many patients do we have at this moment in different wards of the hospital, and also in the intensive care unit. I have to say that we got a maximum of 130 patients hospitalized due to COVID from all, not oncology, but all specialties, and also 30 of them was the maximum number of patients in the intensive care unit. Also, it was important to report on some colleagues that could have infected during their duties. In fact, no trainees were infected, despite the fact that those were upfront most of the time, and 5 of the members of the staff got infected, and they had to be sent home, and none of them was seriously ill at any time. And to end this meeting, we discussed the distribution of tasks for the day, including the emergency room and the taking care for the hospitalized patients. May I have next slide, please? At the end of the day, the topics were more or less following up the previous ones, but first we got a report for the full team of the doctor in charge of the oncology emergency room during the working hours period, how many new patients came, patients who went through the COVID circuit, the final outcomes of the COVID-19 PCR test that were pending or already available, was the protocol again kept or broken depending on the specific circumstances, and also assessing the times or the timing of all the to take a decision and to complete the circuit. So second, we got a similar report by the hospitalization team indicating how our patients were doing, particularly those in the COVID-19 area. And also we had to deal with an issue because we have to select those patients to be seen in a face-to-face meeting versus virtual visits for those not requiring chemotherapy or not requiring urgent issues. So then we closed up this second meeting with a report of the head of the department on the protocols, rules, and issues related to the global activity in the hospital, and also recommendations and advices to those colleagues that were going to stay in the on-call team for that evening. Next slide, please. So in conclusion, I think this activity was really very helpful and made the full team very much engaged during this difficult period. So keeping a team building attitude is essential at any time, but it's even more critical when there is a lot of uncertainty and pressure. So avoiding isolation is essential. So there are many tools to facilitate virtual meetings, and those are welcome, and they were available and can be flexibly used. And I think reinforcing communication under these circumstances may increase efficacy of the whole team, keeping all members engaged in a common task, in a common aim, which is to bring a best care for cancer patients. Thank you very much.
Thank you. Thank you, Dr. Cervantes, for your great and very interesting presentation. And also congratulations for the tremendous job and effort that you are doing, not only in your center, but also in the whole region and the whole country in Spain. I would like also to remind to the audience that we will have a 15-minute Q&A session at the end of the 3 presentations, and that you are very welcome to send your comments or questions through the WebEx Q&A box. Now it's time to present and to introduce our second great speaker for today. His name is Dr. Chite Asirwa, and he is the CEO of the International Cancer Institute in Kenya. He completed a formal fellowship training at the NCA Designated Cancer Center, his internal medicine residency in the United States, and a 3-year hematology and oncology fellowship training at the Indiana University. He is the program director and the PI of the Blueprint for Innovative Access program, and also the Shining Tower program, 2 very important programs, cancer programs, with the objective of optimizing the standard of care and personalized medicine. From 2011 and 2019, Dr. Asirwa was the director of the academic model providing access to healthcare, oncology, and hematology programs, a consortium of a group of North American universities, and the Moi University and the Teaching and Referral Hospital in Eldoret, Kenya. Welcome, Dr. Asirwa, to this webinar, and now is your time for your presentation.
Thank you so much. I hope we can hear me. Next slide, please. So International Cancer Institute is a non-governmental, not-for-profit organization that basically looks at how to optimize care along the patient's journey, from diagnostic, screening, treatment, ensuring that there's access to treatment across sub-Saharan Africa, and specifically in Kenya. We are located in Eldoret, Kenya. So I'll mention a little bit about what we've been doing and our own experiences during this COVID-19 period. We have our main cancer center in Eldoret. It's a cancer care and research clinic, but we are also affiliated to more than 15 counties in Kenya, Kakamega County, Meru, and several others, through various programs and projects that we do with them. Next slide, please. And our main pillars during this collaborative partnership is in clinical care, where we mainly dwell with screening, early detection, diagnostics, treatment, timely referral, as well as patient supportive care services, including navigation in care, as well as education and training as our major bucket, as one of the pillars. Community health, which coordinates various stakeholders within the communities that we serve. There is a component of leadership and administration to ensure that, and as we talk about planning and looking at how resources are being implemented at this time of COVID, to ensure that all that is within specific goals and timelines. We also really work so hard in development of integrated data management systems that integrate cancer care and sometimes with NCDs, but also with various projects those counties are doing. And most importantly, we focus on pathology and telepathology in these centers. Next, please. So during this period, what have we noticed are the most vulnerable within our patients or those who are coming to see us? The symptomatic and diagnosed and newly diagnosed. Those who are currently on active treatment. We've noticed quite a lot of disruption in terms of those who are getting chemo, radio, needing curative surgeries and pain management, because at one point all these hospitals are not accepting elective surgeries at all. And even pain management, part of it is the supply chain for pain management disruption, as well as those who need concurrent treatments, and they are being treated in non-comprehensive cancer centers. So they need partnership between various centers to actually get their comprehensive care. The next group we noticed that had a lot of issues was cancer, those who are potentially having a relapse or recurrence. Next slide. As well as those with very little family support, elderly, nomadic in those arid areas from the communities that we work, and those with poor performance status. Next. So our chief oncology nurse, Pamela Were, did a little bit of survey on clinicians from our partnership sites to find out what are they actually seeing and what are the findings during this COVID. And there were several things that most of them reported. They reported that quite a lot of resources had been reallocated from cancer care to COVID-19, including the human resources as well as just the hospitals themselves. Some of them had actually been turned to COVID centers 100% with little regard to NCDs and cancer care. Some hospitals do not have cancer units, so we would refer patients to these sites and say, can you continue your treatment at this site? And they don't really have a unit, or they don't have supplies for screening. There was quite a bit of lockdown that was done with various counties. So Nairobi being our major city in Kenya, where most of the centers with radiation are located, we could not really send patients to Nairobi because there was a lockdown in and out of Nairobi. And then some centers actually had low turnout of patients, and most of them were stigmatizing healthcare workers, saying that they are the ones who are passing on the COVID to others. And so some of them feared coming to the hospitals. We even had a few centers where people who are working within cancer centers were actually looking for jobs in other departments or had actually been reassigned. Next. And so some of the threats that we noticed during this time were inconsistent messaging, which is really not, it's actually worldwide because we were learning on the go. And so initially what was thought to be at the time when we started all this, and now we are getting a little bit of a handle of what's going on than before. Then these lockdowns also are really not good, and some centers ended up having an increase in more than 25% of cancer patients because they could not really go to another town to seek care. Stigmatization of some of the symptoms. If your cancer patient has a fever or a cough, everybody would actually say this is COVID unless proven otherwise. And so any of these patients admitted to any of the hospitals would require at least 2 to 3 days before we get the results of COVID PCR tests back before you can actually see them. And then various insurance for the patients were not covering some of the hospitals, so accessibility for care was really hard. And then, of course, unsympathetic security forces at various roadblocks were also an issue because patients would travel and then they would be turned back to their various countries without care. And as I said earlier, avoidance of hospitals due to fear of contracting COVID-19 is still something that we really need to work hard on, even as patients start now coming to the clinics. Next slide. So there are several interventions that we did and we still continue doing during this COVID-19. We increased our teleclinics so that patients follow up for those patients who do not really actively need to be in clinic to be seen, like survivorship care. Quite a number of these care can actually be done virtually. Then we signed a memorandum of understanding with several companies to ensure that we can actually transport the specimen to various places for diagnostics instead of having patients move from place to place. So we supply say the biopsy guns and needles to the various sites that we are collaborating with, and then it's collected and the specimen is sent to us for reading. And we are doing the same even for drugs and various supplies across 16 sites with our central lab. The thing that took up so much was the virtual preceptorship. So we converted a lot of our trainings that were face-to-face for breast cancer, lung cancer, colon cancer. We've got more than 30 preceptorship training courses that we converted, all of them virtually. And they are well across sub-Saharan Africa with participants from as far as Nigeria to South Africa, and mostly Kenyans as well. Then we have within patient care planning for each patient on treatment. Now you have, even once you meet your patient, you have to figure out what will be the next visit be. And assuming that visit is actually not going to be with you face to face, what are the arrangements you are making in place for this patient to be seen? So looking at substitute doctors and sending them the protocols for the patient care. And we receive quite a number of patients here at International Cancer Institute from those who are going to Nairobi for care. And we would liaise with their doctors and see what have they gotten the second or third cycle. So we would do the fourth or whatever number of cycles, depending on the protocols they were on. This one was to ease the idea of the patient having to travel with these restrictions, but ensure that they are still getting their care. And then sending their medication to their doctors and sharing protocols. We now have a very strong patient navigator and coordinator service where every patient's specific needs are outlined, even at diagnosis or at every clinic visit. And mental health, we are engaging various other organizations that can assist with this, because we also notice this is one of the areas in which there's a lot of information needed. We developed revolving fund pharmacy. This is arrangements with counties where we sign a contract with them to exchange chemotherapy and supplies, so that when we have disruption of supply chain, there is still patients really getting their treatments at their centers. Next, please. And the other things that more social media, we have doctors and nurses on call now, because we really need patients to be calling before coming to the clinic, so that we have strict screening for COVID-19, even with the questions or even when they come to the gate. Minimizing patient movements. So we are doing a lot of one-stop shop clinics where when a patient comes to the clinic with a mass, for instance, are we able to biopsy, do the blood draws, do comprehensive evaluation and planning, instead of zigzagging them to various centers for care. And more importantly, end-of-life care discussions, asking these patients, what would you like to do? There's been no more time for such kind of discussions than now, and patients really are at the forefront of this, and working together with other organizations, we're able to do this. Engagement of survivors. We've continued having meetings with support groups, of course, with social distancing and all that. But most importantly, there are some county governments that have come strongly in terms of support of cancer patients, whether it's transportation to clinic or assisting them or giving us permission to move even during lockdown, so that we can go and see patients at off-sites. And most importantly, mass screenings that we used to do for breast and cervical cancer can no longer be done just because of what's going on at the moment. So what I have done is working together with those centers to develop in-clinic facilities that can do screening routinely, instead of doing mass screenings as we were doing before. Next. And of course, philanthropic support from various people and petitioning various organs of the government and non-governmental agencies to assist with essential supplies, biopsies, and all that has been very useful at this time. Next. So I acknowledge all these people that have been part of this, including the cancer patients and these communities that we serve. Thank you so much.
Thank you. Thank you very much, Dr. Asirwa, for sharing your experiences with us, and also congratulations. This is very impressive, all the job you're doing, not only with the COVID, but also with all the cancer programs that you are dealing and you are coordinating in Kenya and other sub-Saharan countries around Africa. Just as a reminder, please feel free to send your questions through the Q&A box, so we will be able to address them at the end of the three presentations. Our third speaker is Dr. Fay Hlubocky. She is a clinical health psychologist and medical ethicist in the Department of Medicine at the University of Chicago. She is also a faculty lecturer for clinical medical ethics at this university in Chicago, and also the director for the Fellows Communication Skills Training Program. Her clinical research and education activities are centered on the ethical dilemmas and psychosocial needs surrounding the care of patients, caregivers, and oncology clinicians across the cancer trajectory, especially those involving end-of-life care. Dr. Hlubocky is also the immediate past chair of the American Society of Clinical Oncology Ethics Committee. Thank you very much for being here, and welcome, Dr. Hlubocky, and please go ahead with your presentation.
Thank you, Dr. Rogado. Thank you, everybody. Honor and pleasure to be here. Next slide, please. As the COVID-19 pandemic intensified in the U.S., it was predicted that the crisis will demand additional critical care resources, such as ventilators and the healthcare system could supply, and thus institutions will need to develop allocation decision policies. On April 9, 2020, ASCO released the guidance, Ethics and Resource Scarcity, ASCO recommendations for the oncology community during the COVID-19 pandemic. The recommendations were developed by the ASCO Ethics Committee, approved by the Board of Directors, and published in the Journal of JCO. ASCO affirms the inherent worth and dignity of each patient affected by cancer and recognizes that cancer is a heterogeneous disease that differs in its prognosis, progression, and treatment. Allocation decision processes should not unconditionally deny patients with cancer consideration for access to care resources. Oncologists have a vital role to play in caring for and about their patients if resource allocation becomes needed. ASCO presents the following guidelines based upon core ethical principles used in public health emergencies, centering on the protection of health populations. Next, please. In an epidemic, the primary duty that clinicians and healthcare administration encounter involves maximizing the benefits to be achieved with the limited available resources. The benefits are measured by life saved or life years saved. Life years saved prioritizes individuals with longer life expectancies in the absence of the current acute illness. Priority be given to individuals with the greatest likelihood of recovery from the present illness. Rationing policies for life-saving critical care resources should not utilize the patient's perceived quality of life assessment or perception regarding social worth. ASCO recommends that the core principle guiding allocation decisions in a pandemic be made with the goal of maximizing health benefits gained with the limited available resources. Next, please. In the time of scarcity, clinician duty to care for individual patients must be balanced with the duty to care for the population, the stewardship of resources, and protection of public safety. Oncologists can support informed allocation decisions by providing an accurate, updated patient information such as prognosis or treatment related to the allocation policy. Oncologists should fulfill their patient obligation by provision of compassionate care. ASCO recommends that allocation decisions for patients with cancer not be made by the treating oncologist in order to preserve the oncologist's fidelity to the patient. For example, if there's an ICU bed shortage, a triage officer or committee should be tasked with deciding which patient will be transferred to the ICU via a vetted policy, the named policies identified by ASCO here, rather than the clinician caring for these patients at the bedside. Application to cancer care, the oncologist may not always be able to make the final decisions about care of their patients who might benefit from scarce resources, and they may experience moral distress if unable to provide the care they normally would. Next, please. During scarcity, the duty of clinicians and institutions to steward limited resources is urgent to maximally benefit the greatest number of patients. ASCO recommends that oncologists work with their institutions to consider how best to use scarce resources for care and support of patients with cancer during a pandemic. And this examines whether individual care plans, surgery, chemotherapy, clinical trial enrollment can or should be delayed or altered. The oncologist serves as the patient advocate with understanding that not all will gain access to scarce medical resources in a time of emergency shortage. For example, in the setting of a severe medication scarcity, priority may have to be given to patients receiving the medication with intent to cure their cancer and or for the U.S. FDA administration approved or otherwise evidence-based indication. In cancer, oncologists need to communicate with patients and families about why there is no access to medications or other medical resources in short supply. Next, please. Allocation of resources should be based on ethically relevant differences among individuals, free from unjustified favoritism or discrimination. Determining the relevance of differences depends on clinical criteria and the resource. Allocation policies should recognize the responsibility of fairness and equity in the distribution of benefits and burdens across patient populations. Oncologists should communicate with institutions on plans and allocation decisions regarding oncology considerations, for example, COVID-19 outcomes and cancer, that inform fair allocation plans. Therefore, ASCO recommends that whenever possible, an explicit prioritization and allocation policy be developed before a resource requires allocation. A cancer diagnosis alone should not keep a patient from having a fair chance to access scarce and potentially life-saving resources. For example, if only one ventilator is available, yet two patients need mechanical ventilation, the choice of who will receive ventilator support should be made on factors relevant to the patient's clinical circumstances and specific shortage. In cancer care, clinical factors such as diagnosis and prognosis may be relevant in allocation decisions. A cancer diagnosis alone should not preclude access to scarce medical resources, although clinical considerations significantly affecting prognosis, for example, metastatic treatment-resistant disease, may factor into allocation policies. Next, please. Allocation decisions should be made according to standardized set criteria within a given institution and broadly. Similar patients should be treated alike and have equal access. Criteria should be applied to all patients who may benefit. Oncologists may communicate allocation decisions clearly to patient, public, and with multidisciplinary teams. ASCO recommends that oncologists work with teams at their institutions to promote resource allocation plans to fairly, objectively, and consistently consider patients with cancer. For example, 2 patients with acute respiratory distress syndrome resulting from COVID, same age, comorbidities, treated at the same hospital should receive equal consideration for an ICU bed with a lottery or other random selection method. In cancer, after factors such as the likelihood of critical illness recovery, underlying disease prognosis, and age are evaluated, a cancer diagnosis should lead to neither higher nor lower priority for critical care resources as compared with other similarly situated patients. Next, please. Allocation of scarce resources plans should be developed with input of relevant stakeholder communities to reflect patients and maintain trust. If resource allocation plans cannot be made in advance of stakeholder participation, plans should be made available to the public. ASCO recommends that oncologists become familiar with institutional allocation plans and policies and use the best practices for informed patient communication. For example, triage plans for how the triage committee will make allocation decisions publicly. In cancer, information about how allocation policies will be applied to patients with cancer should be made available to communities of patients with cancer and other affected groups. Next, please. Truthful, compassionate communication remains ethically fundamental during an emergency. Oncologists have a duty to communicate with patients regarding values, goals of care, and end-of-life preferences. Important to engage in early discussions revisiting values periodically to identify patients who prefer non-invasive care to minimize the demands for scarce resources. ASCO urges oncologists to engage in advanced care planning discussions with their patients early and often and encourages the use of advanced directives or other expressions of goals of care, including end-of-life preferences. These conversations should be clearly documented in the medical record. For example, 2 patients have a COVID-19 related ARDS, yet only 1 ICU bed is available. 1 patient has a previously documented advanced directive. He receives some goal concordant supportive care, and the other patient is admitted to the ICU. No rationing decision is required. In cancer, oncologists should explore and document patient values and preferences and goals of care while patients are well. These discussions should be documented and repeated periodically to avoid making challenging decisions under the pressure of time. Next, please. All parties, individuals, institutions, systems involved in planning and implementing an allocation plan should be held accountable. Commitment to transparency ensures accountability before, during, and after settings of resource scarcity. Plans should clearly communicate allocation decisions to patients and families to develop a system of timely appeals and review of these decisions. ASCO recommends that oncologists communicate allocation plans and decisions to their patient with compassion and honesty, and healthcare institutions offer support to oncologists in these communications. For example, institutions participating in allocation decisions regarding scarce ICU beds should review allocation plans and how ICU beds are allocated to ensure a functional system. And in cancer, oncologists should review and provide input on how allocation plans are applied to patients with cancer in the ICU. Next, please. In conclusion, the ASCO recommendation states institutions should develop a fair and consistent prioritization and allocation policy before allocation becomes necessary. Decisions should be made at an institutional level rather than the bedside, so oncologists maintain their duty to the patient. Allocation of resources in a pandemic should be based on maximizing health benefits. Rationing for life-saving critical care resources should not use quality of life assessments or perceptions about patient social worth. Oncologists should work with their institutions on how best to utilize scarce resources for care and support of cancer patients. Oncologists should communicate these allocation plans and decisions to patients with compassion and honesty, and healthcare institutions should offer support to oncologists in these communications. And finally, oncologists should engage in advanced care planning discussions with patients and carefully document patient preferences for goals of care, particularly end of life. Thank you very much.
Great.
Thank you very much, Dr. Hlubocky, for your talk. I think it's a great presentation and also a great initiative to put this in place, this recommendation. Now it's time for a brief discussion and to address all the questions we have received from the audience. We have 15 minutes for this, and I will start with some questions that we have received now. We have here one question for Dr. Cervantes, that they are asking if there is any well-being or emotional support program for the staff in your center.
I'm afraid not. It was provided a kind of psychological advice, but I think the main support we have during that period was the energy and the enthusiasm of all our colleagues trying to keep together during these difficult days.
Yeah, thank you. And also it's very important to plan, because I think that the staff has been suffering a great emotional impact with this situation, and we are seeing that maybe we are going to be the health professional have to be ready for maybe a second wave of COVID-19 in the near future. And how you establish any measure in order to protect the professionals for a possible second wave?
Well, I think we were not prepared for the first wave. We had to get the best of our best judgment, and I think for the second wave we have more resources. I mean, physical resources, more face mask, more protecting points, but really there's no preparation for that plan. I mean, it's just we know better how to act, but I don't know if we could deal with a stronger second wave. That's one of the worries I have.
Yeah, thank you. There's a similar question also for Dr. Chite Asirwa, and it's saying, how is emotional well-being support for the care team in your setting, and how can this supported?
Yeah, that's a very good question. So from our end, we have really not had very specific concrete plans for that support. However, we now have lunchtime meetings where we meet as staff members of the International Cancer Institute, and we talk about discuss issues of burnout and how we can help our patients better. But that is certainly an area that, especially with this prolonged period and then the second wave, and the fact that in Kenya, the numbers are still climbing and the problem is still getting out of hand, that we really need to create some specific programs. And so if there are ways in which even members of this team have some ideas, we are open to that, because I really think we need to support our healthcare workers so that they can even do more. It's an area that we are open to various partnerships on. Thank you.
Okay, I would like our panelists, if possible, to turn on the video during this Q&A session to see. It's always good to see your faces and interacting. Thank you for that. I have another question for Dr. Chite Asirwa, and it says, to your knowledge, are there innovative approaches by the ICI being adopted outside of Kenya, outside of your country? How do you know something about this point?
Yes, so there are some of the programs that have been adopted. So right now, ICI has actually been holding virtual tumor boards every Monday and every Thursday for the last 1 year. And we've noticed over this COVID period, we are having more countries join in. We have more oncologists and various multidisciplinary team members from Ethiopia, from Swaziland, Eswatini, South Africa, Eastern Cape, Rwanda, Burundi. So yes, some of these things are actually, and also inspiring them to do some of their own local within country activities. However, when we talk about a program like Revolving Fund Pharmacy, or where we are assisting patients access their medication on time, I have not seen any other program yet, although we are in partnership with several countries, and we are hoping that their own governments or own various groups can take this up and improve. But I think from the issue of telemedicine and even the trainings online, there has been adoption a lot of this, and I've noticed that a few countries also want to be doing a lot more teleclinics, and we've gotten some requests, how can we partner so that they can start and do it on their own in their countries. So I think there is an interest. Initially when this started, people didn't really know how long this is going to last, and I think as more people are seeing that we have to continue taking care of cancer patients even during these COVID-19 times, and they need our care more than even before. People are looking at what are the other approaches that we can do. So I'm glad to say that there has been a little bit of interest in, especially the last two months, in the uptake of innovative programs.
Okay, thank you. Thank you very much for your question, for your answers. I have one question for Dr. Hlubocky. It says, it is very difficult to keep oncologists away from deciding allocation about patients, as they will know prognosis and patients' preferences better than others. This recommendation may encourage some facility to exclude oncologists from decision about resource allocations. What do you think about this issue, this comment?
Thank you for that comment and question. We completely agree. That was actually the reason that ASCO had asked to engage in these in the development of these recommendations, because many of the recommendations, at least in the United States, are very ICU-based, ICU-focused, completely excluding the oncologists. So we would like to encourage every cancer institution out there to include the oncologist in this decision-making, whether it's allocation committees or in the decision-making, even if it's not that individual oncologist, an oncologist needs to be included when it comes to cancer cares. So our hope is that these recommendations help to provide a guidance to not just the oncologist, but particularly the institution. And that's how it was framed as well.
Great, thank you. I have one more question for you. Do you know if these recommendations may impact insurance coverage for cancer patients, such as denying critical care services or others?
We are not aware of that, at least in the United States. No, not that we're aware of. Again, within the United States, everyone has a right to receive, especially palliative care now has become almost a standard. Of course, every individual policy may differ, but that is not the goal. In fact, especially now with COVID, I'm sure many things will be changing when it comes to coverage. Okay.
Thank you. I have another question for Dr. Cervantes, and as we know, this public health crisis is being it looks like it's running in parallel with a new economic crisis around the world. Do you think it will be some? How will this impact the economic crisis? How will this impact some health systems, like for example the Spanish one, or what is your perception? What do you think about this situation?
Well, I think it could be quite serious, but I think it's time to underline the importance of values. I think if we have a public system aiming at providing the best possible care for patients, I think it is time to reinforce our system very much. I think I would be in favor of that. Of course, I understand it's going to be difficult, but I think it's a matter of prioritization.
Okay, thank you. Dr. Chite Asirwa, any comments about this topic, about economic resources as well in your setting?
Yeah, I think, the issue is we are looking at this as it's not a sprint. We are looking at it as a marathon. And so I really think one of the major issues is how can resources be reallocated so well that even as we take care of COVID-19 patients, and even as we look at, measures to decrease the spread and all that, we are not forgetting that we already have people with NCDs and especially cancer who still needed the same healthcare services before this. So there is that economic issue coming in, and especially in Kenya, because we've had a lot of lockdowns, and we've also had the issue of having curfew, so that after 9 o'clock at night you cannot continue, and various restaurants and bars and quite a lot of this economic activities being disrupted. So we are hoping that reallocation, and this topic is very, very important. How do you really reallocate some of these resources to ensure that it's not only equitable, but we are not forgetting that we already have patients that we need to take care of. So I think it will still be an issue in our setting.
Mm-hmm. Thank you. And Dr. Hlubocky, your opinion about this issue, and also your perspective from the US. Do you think that the economic crisis could impact the cancer care?
It's my hope. Cancer is expensive already to begin with, at least, especially in the United States. And I hope, and it is our hope and goal that as a cancer community that we can bond together and gather together to be able to advocate that individuals truly deserve cancer care, that this cancer care be not expensive, and that it's, again, our hope and our goal that every cancer patient is, again, worth the dignity of receiving care, despite the financial difficulties that might experience. But yes, I'm sure that COVID will be impacting many institutions across the world, but especially here in the United States. But I think as a community, we will bond together and advocate for the cancer patient. Yes,
sure. Thank you. I have some more questions. This for Dr. Cervantes and Dr. Chite Asirwa. Some attendees ask about any recommendations for patients with neutropenic fever and COVID-19.
Well, I have to say that I would recommend, which is standard of care. So I would support those patients with wide spectrum antibiotics plus GCSF. And also, if they have active COVID, I would support them from the respiratory point of view, taking care of coagulation issues and providing respiratory support as the best standard of care.
Dr. Chite, any?
So for me, I'll totally agree with what has been said. I would only add that for any patient you think they are likely to get into neutropenic fever, there is a lot of things we have to be doing, including even just having them carry around a note that says, this is a patient who is actively on treatment. We are treating for XYZ and is likely to have fever from neutropenia. Because one of the problems we've encountered is a patient with neutropenic fever gets admitted. And the hospital, obviously, they tick on the COVID-19 wing of testing and all that. However, some of the results are taking long to come. So you end up staying for 3 or 4 days without seeing your patient until the results come back. And it's only when it's negative that they are allowing you to actually see the patient and take care of the neutropenic fever. So I think part of our approach now is to ensure that we are educating the patient a lot more and ensuring that they have all the information they need. And whenever they have a fever, they call fast, so that they are not ending up in a hospital without us guys knowing and arranging their care. So otherwise, the rest of the care is as per standard care.
Thank you. We are running out of time. We have time for the last one, for Dr. Hlubocky. It says the ASCO guidelines on resource allocations are particularly thoughtful in how they advocate for those with cancer. The question is there any interest on the federal level to develop uniform allocation guidelines applicable nationwide?
I think that's difficult. Even in the development of our recommendations, we were really thoughtful because every cancer institution is different. So, for example, the community cancer center might be very different in that hospital associated with it. They might have fewer ICU beds than, say, the academic center. So again, most of the policies that are at least being developed here in the United States tend to be institutional. Sometimes the state may adopt a certain policy dependent. The states have their own policies, some of them. It's not uniform across, but our goal was really to help to provide guidance. Again, these are recommendations, but also being very thoughtful that it has to meet that cancer center and that cancer institution. We did not want to impose burdens, but yet we really wanted to guide our ASCO members that were informing us that the COVID epidemic was impacting cancer care adversely.
Well, thank you. We ran out of time. I would like to specifically thank you all the 3 speakers for the great job and contribution to this webinar. Also remind to all the attendees that you can visit the ASCO COVID-19 resource centers for more information. And sorry for not being able to answer all the questions that we have received due to the lack of time. Thank you very much for being here. Now I hand over to Doug Pyle for the wrap-up and conclusions. Thank you.
So thank you, Alvaro, and thank you so much for moderating this session so well. Again, I would just like to echo your comments. Thanks to our three speakers, really three outstanding talks. From Dr. Cervantes, we heard very concrete, very practical insights into how to keep the care team engaged, so critically important. From Dr. Chite, insights into the impact of COVID-19 in sub-Saharan Africa and the innovative ways that ICI is responding. And it's great to hear that many of those approaches are being taken up broadly in the region. And finally, from Dr. Hlubocky, excellent, very helpful guidance from ASCO on the allocation of scarce resources during the pandemic. Finally, I'd also just like to thank all of the participants and their excellent questions, a great dialogue, and so very helpful. Just to highlight a few things, just to remind everyone that we do have an upcoming webinar, so the end of August 25th, the next iteration of our webinar series. We do encourage you to submit recommended topics to the WebEx survey, which you'll receive after the webinar concludes. As was mentioned before, the recordings will be posted on the webinar series page. We do encourage you to share the recordings with your colleagues who may be interested. And if you would like a certificate of attendance, please email us at international@asco.org. You can see the email address there. Once again, thank you to all of our speakers, to Alvaro, to all of you, and please take care and stay safe. And thank you again.